Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota. Thank you all for joining us for today's podcast titled Violence in Sleep. Reports of court cases in which defense attorneys claim that acts of violence, including homicide, have occurred while the accused is sleepwalking generate considerable public interest. But can these really occur, and do sleep specialists really have a role in solving these cases? To answer these questions and discuss violence in sleep, my guest today is Dr. Michael Silber, professor of neurology and a board-certified sleep specialist at the Mayo Clinic in Rochester, Minnesota. Mike, thank you for joining us today. Let us first start by having you describe for us the spectrum of violent behaviors that can occur with parasomnias.
Thank you, Maitri. The answer to that really depends on what is the underlying cause. So let's start with REM sleep behavior disorder, in which patients act out their dreams. In 2000, my colleague, Dr. Erik Olsen, and I published a large series in the journal Brain of 93 patients that we had seen to date with REM sleep behavior disorder. And what we discovered was that 32%, basically a third of those patients, described injuries to themselves. Patients had fallen out of bed, they had struck the walls and furniture with their arms flailing out. We had patients with lacerations, abrasions, fractures, ecchymoses, and 2 of the patients actually had subdural hematomas from falling out and hitting their head on some object on the floor or on the wall. So one patient actually grasped Venetian blinds on his windows, these hands, and had multiple lacerations across his hands. Another patient kicked a hole in the wall. One patient actually tried to get out of a window, which is very rare in REM sleep behavior disorder. And one patient had a gun in the bedroom and pulled it out and tried to fire it down the hall, dreaming obviously he was being attacked, but thankfully there were no bullets in the gun. So injuries to self in REM sleep behavior disorder are common. Most are not as serious as some of the ones I've described today, but they can be. And then the injuries to others. Of our 93 patients, 16% described injuries to their bed partner, to their sleeping partner. Of course, as I always point out to the patients, of course it's inadvertent. This is you're dreaming that you're being attacked by someone else, not by your partner. But partners in our series, and in my experience ever since, have been punched, slapped, kicked, their hair pulled. I had one patient whose front teeth were knocked out. That's a very serious and unusual one. I've had a couple of patients, and there was in our series, who were bed partners have woken up to find their partner's hands around their neck trying to strangle them. These are not minor things at all. There have been patients who've had black eyes from punching. And I mean, when you think about it, if you see a middle-aged or older woman walk down the street with 2 black eyes, the first thing you think about is she a victim of domestic assault? And in some sort of strange, twisted way, she is. But of course, not the way we think about it. The bed partners are always utterly remorseful about it. I mean, they are just so upset that they have been hitting or their bed partners. As you know, the disorder is more common in men, so probably about 2/3 or so. So it's more often a woman who gets assaulted in these cases, but not always. So these are serious potential problems of REM sleep behavior disorder. Then if we move to the non-REM arousal parasomnias, sleepwalking predominantly is what we're talking about. But perhaps before we go there, I should just add that I'm not aware of any homicides described with REM sleep behavior disorder, despite the seriousness of some of the assaults. And I've certainly never seen it, and I've never read about somebody actually resulting in death through these assaults. So let's move to sleepwalking. The majority of people who sleepwalk are children. Injuries can happen, but we're more concerned often about adults who sleepwalk. So what can happen? Well, remember, a person who sleepwalks, a child or an adult, is in a sort of dissociated state. They don't react properly to the environment, and so things can certainly happen. They can bump into furniture, bump into doors. They can fall out of bed sometimes as they're trying to get out of bed to start sleepwalking, or if they've had an attack of a sleep terror, they can throw themselves out of bed. Stairs are a particular problem. They can fall downstairs. And the ones which I've seen perhaps most prominently in sleepwalking as injurious is getting out of windows. Now, that's a minority of patients, of course, but I've had several patients who've thrown themselves out through windows. Often there's a sort of image of intense danger in the bed. The bed's on fire. Something terrible is going to happen. They jump out of bed, and if the window is there, they can throw themselves out through glass. I've had one patient who has got chronic pain in her face because she damaged some of her trigeminal nerve fibers going through the glass of a window. And the most severe patient I've ever seen was an unfortunate young man who threw himself out through a window, landed on the ground 2 stories down, and was permanently paraplegic from a fractured spine. But that's obviously unusual. And then people who sleepwalk can leave the house. I mean, they can get out through the front door. We are familiar with occasional cases of sleep driving, though usually without injury, surprisingly. But people can wander at night, and that can be dangerous. So there are a number of ways in which they can hurt themselves. What about sleepwalkers hurting others? Now, there's a history going back centuries of reports of people probably sleepwalking who may have committed homicide. And I think it's established that extremely rarely that can occur. I mean, it's news when something like that happens, but it can happen. Minor assaults on people can happen, and usually what it is the person is sleepwalking, and somebody, a bed partner, or others, tries to restrain them, to direct them back to bed. In that confused state, they lash out. So some injuries and assaults can certainly happen that way. Now, I think later in this podcast or the next podcast, we'll come back to homicide, but these are the sort of things can happen. There's one variant of sleepwalking, non-REM parasomnia, we call the sexsomnias, where for reasons we don't understand, patients' behaviors in this confused, dissociated state become sexual. I mean, when you think about it, it's not that surprising when you think of the fundamental biologic urges of sleep, sex, eating for that matter. A lot of them are centered in the hypothalamus. Obviously, the circuitry is extremely complex and goes way beyond the hypothalamus, but it's not surprising that when one goes back to primitive dissociative behavior with the cortex only partially functioning, that sexual behaviors can occur. And sometimes it's as simple as self-masturbatory behavior, but on other occasions, there are attempted sexual behaviors with the bed partner who happens to be sleeping there. And it can be anything from just fondling through to forced intercourse. So we do see sexual violence, again, totally unconscious, not at all driven by anything malicious or criminal, but you can imagine the medical legal consequences can sometimes be severe.
So, for patients whose parasomnia behaviors have at times been violent, Mike, what sort of precautions and advice do you go about recommending for the patients and or their bed partners?
Yes, that's terribly important. So every patient I see with REM sleep behavior disorder, diagnosed, usually middle-aged and older people, no, not always, and usually men, but also not always, I go into the safety of the bed environment. I ask, is there a carpet on the floor or hardwood floor? If it's a hardwood floor in the bedroom, I might recommend putting a carpet, a throw-down rug there, or maybe some cushions so that if the person does throw themselves out of bed, there's at least a soft landing. If there's a history of lashing out with the arm onto the um, table next to the bed, we might move the table away if possible, or cover it with cushions or something like that. I always ask about guns. If there are guns in the bedroom, I try to urge the person to remove them. If they feel that's not appropriate, at least see they're not loaded and that the ammunition is somewhere where they can't easily get it. Um, some people have actually built barriers in the bed between them and their partners to avoid disturbing their sleep or injuring them, which is fine. There's an interesting study from Minneapolis. Mike Howell was the neurologist who did it about with bed alarms, where there's an alarm in the bed, and when excessive movement happens, there's a recording by the person's partner saying, "Darling, nothing's wrong. You're not being attacked. Go back to sleep, relax." And apparently it works well, though I don't have any real experience with that. Then medications. One of the reasons for treating these medically is to avoid injury. Of course, it's also to avoid disturbance to the bed partner, but injury to the bed partner or to the patient themselves. So we start with melatonin, and if that doesn't work, we'll go on to clonazepam. Of course, there are many more side effects, but for many patients, 12 to 15 milligrams melatonin is sufficient to calm the movements down, not necessarily stop them. Otherwise, 0.5 milligrams to 2 milligrams clonazepam is 90% effective in reducing the movements, but their side effects in older patients, especially if they're developing the neurodegenerative disorders sometimes associated with REM sleep behavior disorder, you may not want to use that. And then, when it comes to the partner, sometimes the best answer and the safest for both of them is to just sleep in a separate bed. If they really like being in the room together, move into two smaller twin beds next to each other, maybe with a little gap in between. And that's often, if we follow sort of the principle, don't do any harm, that may be a lot easier than putting people on clonazepam, if the real reason for the clonazepam is to avoid them injuring their bed partner. For non-REM parasomnias, sleepwalking, it's important to control predisposing factors and precipitating factors. Just see that there's nothing that's obviously waking them up during the night. It's untreated sleep apnea in an adult often, especially. Then safety, it depends what behaviors they do, but gates on the stairs may be very important for children and for adults if they're going downstairs. If there's a tendency to throw themselves towards windows, very important to put heavy drapes on the windows, often move furniture in front of the windows to see that they really can't easily throw themselves out. Most often the patients who've done that don't walk to the window, open drapes, they throw themselves through. So if there's heavy drapes and furniture blocking the way, you may be able to avoid that. Um, and then if they're leaving the house, see that the doors of the house are locked and that they can't get to the keys, that they're not just sitting in the lock, and if necessary, even a bolt high up on the door might be helpful. If they drive in their sleep, which is so rare, just see that the car keys are locked away somewhere where they can't easily find them in a sort of subconscious state. So all those are things we do to try improve safety. Again, for the non-REM parasomnias, if there's injurious behavior, often we will use clonazepam in an adult as the first line pharmacologic treatment. And often they're younger people who tolerate clonazepam much better than the older people with REM sleep behavior disorder. And I have very good results, again, of 0.5 milligrams to 2 milligrams. Children will try and avoid medication as much as possible, try behavioral techniques and improving safety, but in some cases, medication is also needed in children with injurious sleepwalking.
That's very helpful, Mike. So, taking that a step further, are there any factors that would lead you to believe that a serious act of violence may have occurred while an individual was sleepwalking?
Yes, now we're getting onto medical legal things, aren't we? These are patients who may or may not have committed a serious act of violence up to and including homicide in a state of sleepwalking. Well, there have been several sets of criteria put forward by experts over the years, and I'll sort of list the ones that I think are most important. The crime, if it is a crime, should be motiveless. If there's a clear reason this is somebody's enemy who they've assaulted or killed, it's sort of hard to convince anyone that it was done while sleepwalking. There should be little or no attempt at concealment of the crime. I mean, to take to take a sort of example, if somebody picks up a body, puts it in the trunk of their car, drives out into the woods and buries the body, it's very hard for one to then argue that that occurred while they were sleepwalking. There should be at least partial amnesia for the event. If the person at some stage describing it could describe every moment of the assault, that's not likely to be sleepwalking. There should be perplexity, horror even, and complete remorse when described what the person allegedly did. The person should just say, I can't even believe that I did such a thing. The events should usually occur after forced sudden arousal. Somebody disturbed the person during the episode of sleepwalking. Classically, it should occur early in the night because that's when most slow wave sleep is there. And remember, for these severe assaults, we're not talking about REM sleep behavior disorder. We're talking about non-REM sleepwalking. But I don't think we'd pay a lot of attention to that. But very important, I think there should be a prior history of sleepwalking. If the person never had an arousal parasomnia in their lives, and then suddenly they say that the assault or the homicide was due to sleepwalking, it's a little hard to believe. And finally, alcohol should not play a role. It just complicates the matter totally, trying to work out what effect the direct toxic effects of alcohol on the brain and the mind could be playing. If the person was drunk or intoxicated or had heavy alcohol intake, I don't think we should even be beginning to think about this as a sleepwalking incident. They may or may not be responsible for their act, but it's related to alcohol. So those are the sort of things that I think we should consider as we deal with these very complex cases.
So, do you feel that sleep specialists who only occasionally would see cases such as these really make the call?
I think that's a very important question, and I'd answer unequivocally no. These are very complex cases. There may at the end still be no clear answer to it. After working through the whole thing, there may still be doubt. They're time consuming, they need expertise. And I would tell you honestly, Maitri, I don't take them on myself. I don't do medico legal work. I mean, I see these patients occasionally, and if they're my own patients, I may give an opinion, but I don't take on medico legal cases of violence during sleep. The reasons are they're extremely time consuming, they're very disturbing, and even for experts, it's very hard to determine if this really is sleepwalking or not. It also takes physicians out of our normal ethical realm where we are committed to doing the best for the patient and into the sort of legal realm where we're trying to find the truth. And the truth may not always be in the best interests of the patient. It gets into medical confidentiality. The patient has to give up some of their medical confidentiality and allow and understand that the opinion will be shared legally with others, even if it's not in their interest. There are people around the country who are experts in this, and in general, I think these cases should be dealt with by experts who have specialized in medico-legal sleep medicine. If there's nobody and one feels it's in the interests of the patient to take them on, fine. But I'd be very cautious. Certainly, it should be people with experience in parasomnias for sure. I think for a general sleep physician whose main work has been in sleep apnea, I think it's somewhat dangerous to take these cases on. One might get oneself into some trouble with cross-examinations and things.
That's also very helpful, Mike. Definitely very complicated in addressing some of these issues. Are there any final messages that you would like to leave with our listeners today?
Well, I think at this point, I would say that violence during sleep does occur to the patient and to others. It's remarkably common in REM sleep behavior disorder, very rare in sleepwalking, but can be serious and severe. One needs to be conscious of it. One needs to counsel patients about prevention of violence and know how to treat it. But not to think that serious assaults and things are occurring every day in this sort of state. So, yes, it's important for sleep specialists to be aware of these things and know how to manage them or to refer them on.
Thank you, Mike, for that very useful discussion of violence in sleep. And to our listeners, this concludes our first part of violence in sleep. Please join us again for the next podcast, where we will continue the discussion of this topic by Dr. Silber.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.